Good morning, dear students. After a long time, I'm doing another quick revision series, and today it is about tuberculosis. We will cover it in a very short and crisp manner so that you can rapidly revise it before your exams. See, the tuberculosis is broadly classified into three types basically: pulmonary tuberculosis, extrapulmonary tuberculosis. Of course, bovine tuberculosis is another type of tuberculosis which is among animal population. Now, the problem statement is very important whenever you start writing an answer. So, tuberculosis actually it is one of the biggest disease because it affects 1/3 of the world population, and among these people 5 to 10% will develop the disease. So such is the magnitude of this problem. And among active tuberculosis patients, how many patients will get the disease from the active tuberculosis patient? About 10 to 15% per year will be affected from one active tuberculosis patient. And with respect to other parameters, 8% of all tuberculosis patients are people living with HIV/AIDS. 78% of tuberculosis patients in India belong to multi-drug resistance. This is a worrisome factor. Whereas the world average is 27%. If you compare with the world, it is 27% multi-drug resistant. But in India, it is 78% multi-drug resistant. And it is otherwise called rifampicin resistant tuberculosis. India accounts for 26% of the global burden of tuberculosis. So India is number one in terms of burden of tuberculosis in the world. Followed by second country, which is Indonesia, 8.5%, followed by third country, which is China. It is 8.4% in terms of tuberculosis burden. Also, there is another special type of tuberculosis, pediatric tuberculosis, which accounts for 10% of all tuberculosis patients in the world, and 1 million cases are there in the world. 1 lakh deaths per occur because of MDR tuberculosis and XDR tuberculosis. With respect to treatment success rate in India, it is about 85%, but for multi-drug resistant tuberculosis patients, the treatment success rate is only 57%. For people living with HIV/AIDS and tuberculosis, the success rate is 76%. What are the social factors responsible for the transmission of the tuberculosis in the community? Malnutrition, overcrowding, economic recession, indoor air pollution, tobacco consumption, alcohol abuse, and diabetes. And of course, tuberculosis is such a big problem in our country. In the world, WHO has given some international standards for tuberculosis care. Effective engagement of this is to provide effective engagement of care providers. See, initially it was a stop tuberculosis strategy. Before stop tuberculosis strategy, we have the DOTS strategy in 1994. So this is government committed case detection through predominantly passive case finding in DOTS, standardize the short course chemotherapy to all photon smear positive cases, establishment of a system of regular drug supply, establishments and maintenance of monitoring system for program supervision evaluation. This is the first thing which happened in 1994, the DOTS strategy. Thereafter in 2006 came stop tuberculosis strategy. Pursue high quality DOTS expansion and enhancement. Here the problem of drug resistance came. So address the tuberculosis, HIV, multi-drug resistant tuberculosis, then contribute to health system strengthening, engage all providers. Means not only government, the private healthcare providers will also be engaged in this program, because that time in 2006 and all, the major problem for failure of tuberculosis, the private practitioners were not following the government protocol. So to engage them, the stop tuberculosis strategy gave more importance. Empower people with tuberculosis and community, enable and promote research. All these things were given in importance. Then came in 2015 end tuberculosis strategy. Here the integrated patient-centered care and prevention is given more importance. Bold policies and supportive systems were implemented or trying to be implemented. Intensified research and innovation. This is very, very important to permanently erase tuberculosis from our world. So the stop tuberculosis strategy, the following factors were given more importance for control of tuberculosis: case detection, treatment success, incidence, prevalence, and death rate of due to tuberculosis. Now, according to the end tuberculosis strategy, the goal is very ambitious. That is, by 2035, 95% reduction in cases and 90% reduction in tuberculosis incidence has to be achieved. That is the ambitious goal of WHO. But what are the threats? Like COVID pandemic poses a very big threat to tuberculosis control from our world. Whenever you write about global plan targets, you have to write about 90-90-90 target. That is, reach at least 90% of all people with tuberculosis and place them all on appropriate therapy. That is first line, second line, or preventive therapy, whatever is required. 90% of the key population, the most vulnerable third at-risk population, should be covered. Third, 90% treatment success should be achieved for all people diagnosed with tuberculosis through affordable treatment services, adherence to complete and correct treatment, and social support. So always write about the 90-90 2090 target. Now coming to India, in India constitutes, already I told, 26% of global burden, and the incidence in India is 193 per 1 lakh. Treatment coverage in India is 82%, and the tuberculosis case fatality is 17%, and the incidence of HIV with tuberculosis is 71 per 1 lakh, and incidence of multi-drug resistance is 124 per 1 lakh. These values are very important. Now the classification of tuberculosis, we have to write based on four things. One is based on anatomical site, that is pulmonary or extrapulmonary tuberculosis. Second one is based on HIV status. It is HIV positive tuberculosis or HIV negative. Third one is based on drug resistance. So based on drug resistance can be classified like mono resistance. If the resistance to one first line drug, then it is mono resistant. Polydrug resistance, when there is resistance to more than one first line anti-tuberculous drug, that is both isoniazid and rifampicin, then it is polydrug resistant. Multi-drug resistance, resistance to at least both isoniazid and rifampicin. Extensive drug resistance, here the resistance to any fluoroquinolone and at least one of the three second line injectable drug, that is capreomycin, kanamycin, amic acid, in addition to multi-drug resistance. So that is extensive drug resistance. Then rifampicin resistance. This is resistance to rifampicin directed using phenotypic or genotypic method with or without resistance to other tuberculosis, anti-tuberculosis drugs. So this is third class. Fourth one is based on history of previous tuberculosis treatment. New patients who have never been treated for tuberculosis or they have taken anti-tuberculosis drugs for less than 1 month, and who is relapsed. Relapse is previously treated for tuberculosis and were declared cured or treatment completed at the end of their most recent course of treatment and are now diagnosed with a recurrent episode of tuberculosis. So here the patient is declared cured, but again he got tuberculosis. That is relapse. Whereas treatment after failure is previously treated for tuberculosis but declared lost to follow up the end of their most recent course of treatment. So they were previously known as treatment after default. Treatment after failure, that is those who have previously been treated for tuberculosis and whose treatment failed at the end of their most recent course of treatment. Treatment after loss to follow up, that is the patients have previously been treated for tuberculosis and were declared lost to follow up at the end of their most recent course of treatment. So these are the four types of classification. Now coming to the agent factors, Mycobacterium tuberculosis is the most important facultative intracellular parasite responsible for tuberculosis. Recent years there is atypical mycobacteria which is causing tuberculosis, like photochromoges, Mycobacterium kansasi, scotochromoges, Mycobacterium scrofulaceum, non-photochromogens, Mycobacterium intracellular, rapid growers, Mycobacterium frotutium. So atypical mycobacteria also plays a role in recent times. The source of infection, it is the human source, which is the most important source, and as I told in the beginning, each active patient will transmit at least 10 to 15 persons in the within 1 year. So there are two types of strain in source, that is one is rapid multipliers, another one is slow multipliers. Rapid multipliers, they are more susceptible to bactericidal drug, but low multipliers, they are not susceptible to bactericidal drug, so they become dormant and they are the bacteria that is responsible for relapse. Next source of infections can also be bovine in case of bovine tuberculosis. The communicability, see the patient if untreated, he is lifelong communicable, but once treatment is started, within 48 hours 90% of the cases will become asymptomatic, will reduce infectivity. So the infectivity will reduce by 90% within 48 hours of starting treatment. Host factors, see the 0 to 14 years age group, only 2% of the people are affected with tuberculosis, whereas in 15 to 24 year age group 20% are affected with tuberculosis. It is more prevalent in males. Heredity, it is not a hereditary disease. Nutrition, see malnutrition is a very important component factor responsible for development of active disease. Immunity, so man has no inherited immunity, either he has to get natural infection to get immunity or BCG vaccination to get immunity. What are the social factors? See the poor housing, overcrowding, population explosion, undernutrition, smoking, alcohol, lack of awareness, large families, early marriages, lack of education, all these are social factors responsible for disease. What is the mode of transmission? The mode of transmission is mainly by coughing. So it is not actually transmitted by fomites. It's not really important. Most important route of transmission is by coughing. Incubation period. See, right from the receipt of infection to the development of positive tuberculin test, it takes about 3 to 6 weeks. So that is the incubation period. It also depends upon the closeness of contact, extent of disease. See, thereafter, after infectivity, the possibility of developing a disease depends upon closeness of contact, extent of disease, sputum positivity, etc. Now coming to the control of tuberculosis. These are the two main components in the control of tuberculosis. First, curative component and preventive component. These two are very important in control of tuberculosis. In curative component, we have case finding and treatment. In preventive component, we have BCG vaccination. So this is the overall. Now coming to the each thing, case finding. See, the case finding is the first step in tuberculosis control program for detection of sputum positive cases. It is an intensive ongoing program. Active case finding. Passive case finding is when there is persistent cough and fever. Patients come to the hospital where he is tested for sputum positivity. Then intensified case finding. So people whoever seek the health care, not for tuberculosis, but with or without symptoms or signs of tuberculosis. But as a part of the program, this intensified case finding is done. Those cases who are vulnerable population, clinically and socially, those who are at greater risk of tuberculosis, they will be undergoing the screening process. Especially the vulnerable population, they will be assessed by sputum test. And intensified case finding is this. Vulnerable population will be is given more focus for intensified case finding. Then screening strategies. See, community screening and institutional screening. Community screening is we go to the population by mobile facility where we do the screening. Institutional screening is in healthcare facilities. Now, what are the case finding tools? We have microscopy, culture, drug sensitivity test, rapid molecular test. Microscopy, Gill-Nielsen staining, fluorescence staining. Culture is Lowenstein-Jensen media, LJ media, BACTEC. These are all used in culture. But the problem with culture is it will take a long time for the result to come, 2 to 8 weeks. That is a problem. Photo microscopy is easy to diagnose, but sensitivity is very low. Coming to the drug sensitivity testing, modified proportionate sensitivity testing, PST, MGIT 960 system, and economic variant of proportion sensitivity testing using LJ medium. These are drug sensitivity testing. But these DST is now replaced by rapid molecular test because it is becoming very famous because of the speed and accuracy. Line probe assay is used, especially for detecting resistance. It is very useful, molecular test. So line probe assay is very useful in detecting the resistance, and CBNAT is very useful in diagnosis and as well as in identifying the resistance. So these days, rapid molecular tests are getting more importance. So slide reporting in Gill-Nielsen staining, once the positivity come, we classify as 0, scanty, plus. So these are all the results based on the number of AFB per 100 oil immersion field, first 3, and the last 2 number of AFB per oil immersion field. So this is how we give slide reporting. Then tuberculin testing. This is a 2-step testing, and this was the only available for estimating the prevalence of infection in a population. So remember that still, even though it was discovered in 1907, tuberculin test is the only test still now available for estimating the prevalence of infection in a population. So here, what do we use in this tuberculin test? In India, we use PPD RT23 with tween 80 strain to identify the infectivity. So remember this, PPD RT23 tween 80. This tuberculin test is given in the left forearm, 0.1 ml intradermally in the flexor aspect of the left forearm. We give midway between the elbow and the wrist. The test is read after 48 to 96 hours, preferably 72 hours. So the reactions exceeding more than 10 millimeter are considered positive, 6 to 9 millimeter are doubtful, less than 6 millimeter is negative. Next is tuberculosis interferon gamma release assay, IGRA we say. This IGRA is mainly used to assess the person's immune system. It is not directly measuring the tuberculosis here. Here, what is measured is the cytokines. What is the cytokines level in the population? What is the capability of the person's immune system to deal with tuberculosis? So the IGRA is mainly used to identify latent tuberculosis infection. It is still under trial. Now let us move to from case finding, let us move to the treatment part. The treatment part, we use first line drugs and second line drugs, chemotherapy drugs, that is anti-tuberculosis drugs. So we will go to the next slide. See here, first line drugs and we have second line drugs. In the first line drugs, we have to classify them into bactericidal, bacteriostatic. So in the first line drugs, the only drug which is bacteriostatic is ethambutol. This ethambutol will prevent the multiplication of tuberculosis bacilli. All other drugs here will kill the tuberculosis bacilli. Rifampicin, INH, streptomycin, pyrazinamide will kill. So remember, rifampicin has a side effect of hepatotoxicity, gastritis, influenza-like illness, purpura, thrombocytopenia, nephrotoxicity, and it turns the urine red. Very common common side effect of rifampicin. And next one is INH, isoniazid. It is acts on rapidly multiplying bacteria. It kills, but it doesn't have bacteriostatic property. The side effects are gastrointestinal irritation, peripheral neuropathy, blood dyscrasia, hyperglycemia, and liver damage. So because of peripheral neuropathy, along with pyridoxine, along with INH, we give pyridoxine 10 to 20 milligram daily. Remember this. Next is streptomycin. Streptomycin, the problem is it is a injectable drug and it can cause vestibular damage and nystagmus. So it can cause ENT complications. Next is pyrazinamide. Pyrazinamide increases the sterilizing activity of rifampicin. So the combination of rifampicin and pyrazinamide is very, very effective, especially for tuberculosis meningitis, which affects the brain. The complication of pyrazinamide includes hepatotoxicity and hyperuricemia. Very interesting complication is hyperuricemia of pyrazinamide. Now we will move on to the ethambutol, which is a bacteriostatic drug. The major side effect of ethambutol is retrobulbar neuritis. Let us now move to the second line drugs, fluoroquinolones. That is ciprofloxacin, ofloxacin, levofloxacin, moxifloxacin, gatifloxacin are all fluoroquinolones used in as a second line drug in MDT. And ethionamide is structurally related to INH, especially it's effective against atypical mycobacteria. Capreomycin, it is a bactericidal drug. Kanamycin, amikacin are bactericidal drugs. Cycloserine is bacteriostatic drug. Thiostazone crosses the placental barrier, so it is also secrete milk. So it should never be used in HIV patients. It can cause severe and fatal reactions. Thiostazone. Side effects include gastro disturbance, blurring of vision, hemolytic anemia, urticaria. So it has a lot of side effects. Very careful. We should be very careful about this thiostazone drug. Macrolide antibiotics, azithromycin and clarithromycin can be used. Bedaquiline is a newer group of anti-tubercular drugs, especially targets the mycobacterial ATP synthase. It's a bactericidal drug. Pregnancy is a contraindication for bedaquiline. Cardiac arrhythmia is a contraindication for bedaquiline. Age of the patient should be more than 18 years. So remember these 3 points with respect to bedaquiline. Now next one is delamanid. Delamanid is a recently approved drug for treatment of tuberculosis. 50 milligram is given, especially for MDR tuberculosis. Now coming to the approaches of tuberculosis control. Initially we used short course chemotherapy. In 1972, this short course chemotherapy was introduced. Intensive phase and then continuation phase. In intensive phase, we are trying to kill the bacteria. So using the all INH, rifampicin, pyrazinamide, streptomycin and ethambutol. Then for the next 2 months, we use continuation phase, INH and rifampicin. But this is a older thing, short course chemotherapy. Now DOTS. DOTS was introduced later. This is supposed to be the most effective program. On a program basis, DOTS strategy is very effective. Directly absorbed treatment short course. The patient should follow the drug in the presence of the health worker in intensive phase. In continuation phase, the patient is issued the medicine for 1 week in a multi-blister combi pack. The patient has to bring back the empty pack to get the next dose. So DOTS is a very interesting and very effective chemotherapy strategy in the program. But thereafter, in recent years, now this program is changed in 2016 to daily dose regimen. This daily dose regimen replaces the DOTS. In DOTS, we use intermittent regimen, like weekly 3 times we give. But that is replaced by every day it should be given. Daily dose regimen. It is introduced in the program. In the daily dose regimen, fixed dose combination, that is 4 FDC, that is HRZT. Every day 4 HRZT is given during the intensive phase. And then 3 FDC is given in the continuation phase. Means a 3 fixed dose combination is given in the continuation phase, that is HRE. For pediatric patients, we use fixed dose combination 3 HRZ during continuation phase and 2 HR during 3 HRZ during intensive phase and 2 HR during continuation phase for pediatric patients. Now, whenever you write in exam, this diagnostic algorithm is very important. So, for presentive tuberculosis patient, first is smear examination. When the smear examination is positive or negative, based on that, we go for the diagnostic algorithm. Needed chest X-ray can be taken, and if chest X-ray is also negative, then we go for CBNAT, and then from CBNAT we have to go for mycobacterium tuberculosis sensitivity testing, like whether it is sensitive for rifampicin and all we have to check. Then repeat CB-NAT and then go on for treatment. If the sputum smear is negative, chest X-ray, then again you have follow the same process. For drug-resistant tuberculosis patients, presumptive tuberculosis, all notified tuberculosis patient, non-responder to treatment. Here, presumptive patient, we have categorized them into special categories, PL-HIV, EPTB, smear negative, vulnerable, and based on that, separately give treatment. Otherwise, all notified tuberculosis patient will be undergoing CB-NAT, will be testing for resistance, and then they will be going along same algorithm for treatment. Of course, the treatment here will vary because it is drug-resistant tuberculosis. Here we use second-line drugs. Childhood tuberculosis affects 6 to 8% of all tuberculosis patients. Is childhood tuberculosis occur like active cases of children transmit tuberculosis. Mainly children's tuberculosis occur because there is failure of tuberculosis in adult tuberculosis control in adults. Because of that, it will spread to the child. That is the most important thing. So when do you go for a childhood tuberculosis screening? When there is persistent fever for more than or equal to 2 weeks, when there is unremitting cough for more than 2 weeks, weight loss of 5% in 3 months, or no weight gain in past 3 months. So then you arise a suspicion of tuberculosis and go for testing of tuberculosis in children. So remember, this is a very important algorithm. Same like before, for childhood tuberculosis, here these are the things: persistent fever more than 2 weeks, unremitting cough more than 2 weeks, weight loss of 5%. Then you go for CB-NAT directly. Here for children, first immediately you go for CB-NAT, and then from CB-NAT you proceed whether it is sensitive or not sensitive, chest X-ray, and then go for a treatment. Chest X-ray is needed only if there is if you suspect extrapulmonary tuberculosis, and it is very common in children, extrapulmonary tuberculosis. Now the special group is tuberculosis in pregnancy and lactating women. So the duration of pregnancy, if it is less than 20 weeks, more than 20 weeks, based on that we give the treatment. And similarly, sometimes there could be special emphasis on tuberculosis and diabetes, tuberculosis and HIV, tuberculosis and tobacco, tuberculosis and COVID. These can also occur. So these are co-infections or a non-communicable disease with a communicable disease. I hope for undergraduate level, for tuberculosis question, this level of understanding and knowledge is enough to write in the paper. Even though in the book it is a 36-page document, the whole program document is given there. You cannot write the whole 36 pages in your exam paper. So I have given it in a concise manner about tuberculosis. Try to write all these points in your exam paper. You will get 10 out of 10 for this essay. Of course, I didn't cover national program for tuberculosis. Kindly go into my another video on national program RNTCP for tuberculosis. I have given it separately. Go and watch the program for rapid revision.